So far, we've been talking about surveillance of diseases, mostly infectious diseases, but today we're going to be talking more about non-communicable diseases and surveillance for behaviors and risk factors. In this lecture, we're going to talk about why surveillance for behaviors and risk factors is important, data sources for surveillance of behaviors and risk factors with some examples. We'll look at national level and state level examples and also examples specific to New York City. We'll also assess data on health behaviors and risk factors and look at an application of surveillance data looking at the Ending the AIDS Epidemic in New York dashboard. Here's some data you might remember for the beginning of the course. And this is looking at deaths and years of life lost from the 30 leading diseases and injuries in the United States in 1990 and 2010. What's important to appreciate here is that the leading causes of morbidity and mortality in the US are non-infectious and related to non-communicable diseases and injuries. Here is looking at the number of deaths and percentage of disability-adjusted life years related to 17 leading risk factors in the United States in 2010. And if you think back to the previous slide, you can appreciate how many of these risk factors are in fact causes of these non-communicable diseases. For example, tobacco smoking, high blood pressure, alcohol use. And what you can see here is that these risk factors really account for a large proportion of deaths due to these diseases and injuries. Just looking at dietary risk factors, for example, we see that this is a major contributor to cancer, cardiovascular and circulatory diseases, for example, among others. So by addressing some of these risk factors, we could potentially reduce morbidity and mortality due to these major causes in the United States. Previously, we talked about sources of surveillance data, and as you'll remember, surveys are a major source of surveillance data. And in this presentation, we'll talk about multiple surveys in the United States. And so nationally, there are three major surveys that we use. One is the Behavioral Risk Factor Surveillance System, the National Health Interview Survey, and the National Health and Nutrition Examination Survey. And these all sample civilian, non-institutionalized people living in the United States at the time of the interview. So these are, in fact, representative surveys, but they do exclude certain groups which may be important, like active duty military, persons in long-term care facilities, people who are incarcerated, for example. Let's start with the Behavioral Risk Factor Surveillance System. So this is the nation's premier system of health-related telephone surveys that collects state-level data about U.S. residents regarding their health-related risk factors, chronic health conditions, and use of preventive services. The BRFSS was established in 1984 with 15 states, but it now collects data in all 50 states as well as the District of Columbia and 3 U.S. territories. The BRFSS completes more than 400,000 adult interviews each year, making it the largest continuously conducted health survey system in the world. Here are some BRFSS results from 2011, just to give you an idea of some of the content. And this is for state, micropolitan and metropolitan statistical area and county. And as you can see on the left, there's things like self-rated health, questions about access to care, having received a routine checkup in the past 12 months, having cholesterol checked, questions about vaccinations in the past 12 months or ever, questions about physical activity, smoking, diagnosed diseases, for example. Here is an example from a news media source of how BRFSS data can be used. And here, this is looking at gun ownership and rate of law enforcement homicides per capita. And the survey data on gun ownership actually came from the BRFSS. The National Health Interview Survey has been used to monitor the health of the nation since 1957. It collects data on a broad range of health topics through personal household interviews. So previously, an important point is that the BRFSS that we talked about is telephone-based, and the National Health Interview Survey, also an interview survey, is actually done in person. For over 50 years, the U.S. Census Bureau has been the data collection agent for the National Health Interview Survey. The survey results have been instrumental in providing data to track health status, healthcare access, and progress towards national health objectives. Confidential interviews are conducted in households by Census Bureau interviewers, and the National Health Interview Survey is the nation's largest in-person household health survey. So annually, they interview 35 to 40,000 households, or 70 to up to 100,000 individuals. So this is really a huge undertaking. Here is an example of some data from the National Health Interview Survey, and this is looking at the percent of adults aged 18 and over who met the federal physical activity guidelines through leisure time aerobic activity by age and sex in the United States. So this is self-reported data reported to an interviewer. And you can see here that, just a description of the data, that really only half of adults meet these guidelines, more women than men. But when we look at age groups, we really see a decline in meeting these activity guidelines through age. So an important point with the National Health Interview Survey is that it's also a representative survey based on the sampling technique. So you can get these estimates with good precision about many different health indicators which can help track the nation's health. The National Health and Nutrition Examination Survey is a program of studies designed to assess health and nutritional status of adults and children in the United States. So in contrast to the BRFSS and the National Health Interview Survey, what's unique about this is that it not only has interviews, but it also combines physical examination and specimen collection. So it collects things like blood and urine samples, which can be tested for a variety of things. It includes a nationally representative sample of about 5,000 people each year from 15 counties across the country. It began in the early 1960s, and prior to 1999, it focused on different population groups and time intervals. But in 1999, it started using continuous sampling. And a really interesting aspect of the NHANES is that you can that some of the data are actually linked to death certificates. So you can look longitudinally and see, for example, if people had certain risk factors, look at their trajectory. Did they die of causes? Did they die of diseases related to those risk factors, for example? Its main use is really to determine the prevalence of major diseases and risk factors for diseases in the U.S. And since it is an examination survey, we can get at undiagnosed health conditions, which I'll talk about more in a minute. But the information is used to assess nutritional status and its association with health promotion and disease prevention. And its findings are also the basis for national standards for things like height, weight, and blood pressure. So, for example, like growth curves you'll see in the pediatrician's offices are based actually on NHANES data. You might be wondering how NHANES is done, and actually the CDC uses these mobile examination centers to do the survey. There's different stations in these kind of mobile home type units where there's interviews done, different stations where physical examination is done, and for example, blood specimens drawn, etc. The kind of information gathered in NHANES. So some of the diseases and medical conditions, health indicators included are things like anemia, cardiovascular disease, diabetes, things like environmental exposures, obesity, physical fitness and physical functioning, reproductive history and sexual behavior, anthropometry, so measurement of height and weight, for example. So many different things. It's really a comprehensive survey. Here is an example of some data from NHANES, and this is looking at diagnosed and undiagnosed diabetes in the United States. And here, if you look to the graph on the right, you can see that 7.7% of Americans had a diagnosis of diabetes, and 5.1 had undiagnosed diabetes. Giving us a prevalence of 12.8% or 12.9% with rounding in the United States. So you might be wondering, how do they get at diagnosed versus undiagnosed? And this is something that interview surveys like BRFSS and National Health Interview Survey cannot do. So with those surveys, like I said before, they can ask about diagnosed health conditions. So in NHANES, they also ask, have you ever been diagnosed by a doctor or other healthcare professional with diabetes? And those people who say yes are considered to have diagnosed diabetes. But in NHANES, they also take, a fasting blood glucose sample. And from that, and they also take things like hemoglobin A1C, which is a measure of the average blood glucose over a period of a few months. And based on these biomarkers, they can actually determine if the person has diabetes or not. So if someone has lab work that indicates diabetes, but they said they've never been diagnosed with diabetes before, they would be considered as having undiagnosed diabetes. So this is, as you can appreciate, it's really valuable information. Since in public health, we are, especially concerned with this group of people who are undiagnosed because, without the correct treatment and preventive measures, they'll have worse outcomes than people who have diagnosed diabetes and have control of their disease. Very important slide here. This table compares the BRFSS, NHANES, and National Health Interview Survey on some key attributes. BRFSS, telephone, National Health Interview Survey in person, and NHANES, the survey is done in person, but in one of these mobile examination units, not in the home. Anthropometry, so measurement of height and weight, is self-reported, obviously, for BRFSS and National Health Interview Survey, but it is also measured in NHANES. Physical exam, there's none done, obviously, for BRFSS and National Health Interview Survey, but a comprehensive one is done for NHANES. These are annual surveys for BRFSS and National Health Interview Survey, and NHANES is in fact continuous. Response rates vary. So response rates for the in-person National Health Interview Survey tend to be higher than the telephone-based BRFSS, and I'm sure you can imagine why. People probably more likely to participate if they're asked in person than by the phone. And for NHANES, there's kind of a bit of a lower response rate simply because it is very, very comprehensive exam and does require a substantial amount of the individual's time and also some discomfort potentially related to taking blood for samples. And lastly, the sample size, BRFSS, across the nation is about 400,000, excuse me. National Health Interview Survey, around 30,000 households, upward of 100,000 people. And NHANES roughly about 7,000 people. And these all vary year to year, but these are just ballpark estimates. Let's move on now to New York City data. So we talked about national data and state data, which BRFSS is also done at a state level. But the Community Health Survey is based on the BRFSS, and this is done by the Department of Health and Mental Hygiene in New York City. And this is really like a city version of that survey. It's been annual since 2002. It is a telephone-based survey with a random digit dialing that lasts maybe about 20 or 30 minutes. It is multilingual, so it is done in Russian, Spanish, Mandarin, Cantonese, given the diverse population of New York City. And as you can imagine, a number of people, our households don't even have landlines anymore. So in the later years of the survey, a cell phone component has been done as well. So this also does provide citywide representative estimates for different health indicators. So the Community Health Survey uses a stratified random sample, and this is using 42 New York City neighborhoods. It includes about 8,500 adults, and it's weighted to the New York City population using census data. The topic areas for the Community Health Survey are very similar to those of the BRFSS. They include things like demographics, health behaviors, healthcare access, and health outcomes. And since it is a city-wide survey, the health department can really get at things that are of that are of great importance to the public health of the city, and things that are somewhat unique to the city. Like, for example, asking about things like living in an apartment building, which is not something that people across New York State or the country do, but people in New York City generally live in apartment buildings. So there are a number of limitations to the Community Health Survey, or CHS, and these are not unique to this survey. Being phone-based, there are language and cultural barriers to doing a telephone-based survey, even if it is in your language. There are declining response rates, so this is a survey that is getting harder and harder to do for the health department. The self-reported nature of the data, can be problematic. So there is social desirability bias, difficulty in recalling past behaviors. So just thinking about something like height and weight. So people probably tend to overestimate their height and underestimate their weight. So you will get some social desirability bias related to that. Things when you ask about past health behaviors, some people might have trouble remembering. Since it is a cross-sectional survey, similar to other surveys we talked about, you are unable to establish temporality, so you can determine if a risk factor actually led to a disease. You can actually just only look at the association between the two, and you can only look at prevalence and not incidence. And there are some sensitive questions that may be more susceptible to bias. So like obesity, for example, like I said, You may have skewed estimates from people overestimating their height and underestimating their weight. So we'll see maybe a lower prevalence of obesity than what there truly is. Things like income, also a sensitive question. So people with higher incomes may be less likely to report. So that may be another source of bias if you are looking at income as a variable of interest. Let's look at an application of how some of the survey data can be used for public health action. So Take Care New York 2012 was a health policy agenda from the New York City Department of Health and Mental Hygiene on how to improve New Yorkers' health. And priority areas were mortality, disease and disability, behaviors and exposures that lead to disease, social conditions that can lead to health problems. And there was a focus on children, neighborhoods, and health disparities. Here are the 10 core indicators for Take Care New York. And I would just maybe look through these and think about how can you estimate these different indicators. And we'll look at an example, but I think it's important to appreciate that you really can provide estimates on these indicators through a survey like Community Health Survey. And that surveillance data from that can certainly inform health policy. So one of the Take Care New York goals was looking at adults who currently smoke. So New York City had a 5-point plan for tobacco control, and that included taxation, legal action, cessation, education, and evaluation. And certainly surveillance of tobacco use is really critical to this, to see, what works. We can look at, smoking before and after a major change in policy, how do we estimate smoking before and after that change in policy? We can certainly use something like the Community Health Survey. This slide really summarizes well of how surveillance data from the BRFSS and Community Health Survey can be used in health policy. So the Take Care New York goal was to get the prevalence of adult smokers under 12%. And we can see over time, there was a pretty high prevalence up until 2000. And then we can see all these different changes in health policy and how they impacted smoking. For example, tax increases, smoke-free workplaces, etc. And although this is really in kind of an ecological evaluation, we can see that over time it appears that collectively all of these health policy measures have decreased the prevalence of smokers. And without knowing the prevalence of smokers through a survey like the Community Health Survey, we really couldn't know if these measures were working or not. And before investing, so much money in changing health policy and things like media campaigns, you really need to know, the numbers, what they are, what the current prevalence of smokers are, and what you hope it will be. And the surveillance data from these surveys really does help achieve that. In New York City, there's also the New York City Health and Nutrition Examination Survey, and this was modeled after the National Health and Nutrition Examination Survey conducted by the National Center for Health Statistics at the CDC, like we previously talked about. And this is also a survey done by the New York City Department of Health and Mental Hygiene, and its objectives are similar to the national survey in that it wants to estimate the prevalence of selected diseases and risk factors, but citywide, to estimate citywide awareness, treatment, and control of selected health conditions, examine differences in prevalence, awareness, treatment, and control of selected diseases across demographic subgroups. So, for example, racial subgroups, neighborhood subgroups, and to monitor the prevalence of environmental exposures, some of which are unique to New York City and New York City living, like in apartments. The topic areas for the New York City Health and Nutrition Examination Survey are very similar to the national NHANES. These include physical exam and laboratory analysis, a number of different measures, things like blood pressure, heavy metals, etc. And the data are used to establish baseline levels for important health indicators like obesity, diabetes, mental health, tobacco use, and cottoning. And for those of you who are not familiar, cottoning is a metabolite of nicotine that can be tested for in the blood. So we can look at things like exposure to secondhand smoke through looking at serum cottoning. Here is an example of New York City NHANES data from 2004 looking at diabetes prevalence, diagnosed and undiagnosed groups. And like I said before, this type of survey really helps us get at this undiagnosed diabetes group. And that's something that the community health survey cannot do. So we can see the total prevalence of diabetes in 2004 was 12.5%, a bit higher among men than women, substantially higher in the over 60 age group. We see some racial disparities with blacks having the highest prevalence of diabetes, followed by Asians. We see somewhat of a similar prevalence among US-born and foreign-born, but we see that some of the poorest people have the highest prevalence of diabetes. And when specifically looking at undiagnosed diabetes, we really do see some disparities. So the over 60 age group has a very high prevalence of undiagnosed diabetes. And we also see some differences in other groups, like the foreign-born and the low-income people also have higher prevalence of undiagnosed diabetes. And this information is obviously very helpful because it can help us develop interventions to reach those people who are undiagnosed in the city, to get them diagnosed and hopefully improve their outcomes. Here we're looking at adjusted prevalence of diabetes and impaired fasting glucose by body mass index and race. This is just another example of using this data to look at different important subgroups. So we can see that there is, among normal weight people, a very high prevalence of diabetes and impaired fasting glucose among Asians. This is also true among obese, but we also see, interestingly, among non-Hispanic whites, very high prevalence of obesity, of diabetes and impaired fasting glucose among those who are obese, more so than non-Hispanic blacks and Hispanics. Now, thinking about the public health action aspect of these diabetes findings, well, firstly, you can use these this data to increase public awareness of diabetes in New York City. This can be through press releases, peer-reviewed articles, and other publications. So you can target different groups. So the general population, clinicians, researchers. These findings can inform programs and policies. For example, they can strengthen rationale for primary prevention focus and improve public health guidance on quality care. And these diabetes findings actually guided the development of the A1C registry at the Department of Health. And this provided anticipated A1C levels among persons with and without diabetes. So this is really a great example of a registry that is being used for non-communicable disease that can be used for surveillance in the city. In addition to the New York City NHANES that was done in 2004, there was another survey done in 2013 and 2014, about 10 years later. And this was done in conjunction with the CUNY School of Public Health. And in this survey, about 3,000 randomly selected New York City households were asked to answer survey questions, take a physical exam, etc. And the goal of this was really to provide a picture of the city's health almost 10 years after the first New York City NHANES. So we can really see, for example, how have things like undiagnosed diabetes changed in the city in the last 10 years. There certainly have been a number of important health policy initiatives that have occurred since 2004. So this data allows us to look at the effect of those health policies. The findings also give public health professionals and elected officials the information they need to develop and fund new public health programs, introduce new health regulations and new laws, and educate the public about increasing health risks. Let's talk briefly about accessing these data. So the CDC's National Center for Health Statistics provides public use data files, questionnaires, and reports on the BRFSS, the National Health Interview Survey, and NHANES. They also provide data and other things on other surveys, like the National Survey of Family Growth, National Immunization Survey, and the Longitudinal Study of Aging. The CDC's National Center for Chronic Disease Prevention and Health Promotion also has public use data files, questionnaires, online data analysis tools, and reports. And you can click on this link looking at the BRFSS and other interactive query tools. So you can actually look at different outcomes and see how they differ, for example, among different age groups without having to do any statistical analysis. In New York City, we have EpiQuery, which is a web-based interactive query system. You can look at different health indicators from the Community Health Survey, for example, look at how they're different by neighborhood, look at how they're different by race group. And in addition, there are publicly used data sets. All of this data is publicly available, and anyone is really able to do analysis, provided they have the expertise to do so. So I'd strongly encourage you to look at EpiQuery, look at the BRFSS online query system, and see and just become familiar with these data. This is another important slide, and I just want to highlight some of the strengths and limitations of the surveys used to collect data on health behaviors and risk factors. So some strengths. So they capture important upstream health-related information that is often not available from conventional surveillance. So like notifiable event reporting, vital events, behavioral and risk factors with causal links to health outcomes are what public health practice ultimately focuses its resources on. And this is what we call primary and secondary prevention. So, we're interested in things like preventing the seasonal flu, for example. We really can only inform ways to do that by understanding who's getting flu shots and who's not, for example. Other strengths, they're population-based, they're representative at national, state, and sometimes at local levels. You can compare them across jurisdictions because they often ask or measure the same things, ask the same questions. You can compare, for example, things like diagnosed diabetes in New York State versus Texas, for example. Their questions are asked in the BRFSS in exactly the same way. And another major benefit is that they're often conducted in an ongoing fashion, so you can look at trends over time. Some limitations, so self-report, and this is overcome when objective measures are used in exam-based surveys. So like we talked about previously with diagnosed and undiagnosed diabetes. And so with self-report, like we talked about, there is recall bias and risk of social desirability bias. Another limitation is that these surveys only include non-institutionalized populations. So for example, people in nursing homes, for example, have a very high burden of diseases, but they're not included in these surveys. So you have to think about that as a potential source of bias. There are increasingly lower response rates for many of these surveys, so this may introduce selection bias. And there's also the influence of cell phones, which, later versions of these surveys have really been able to address more successfully. But there are still some issues. For example, you may have you may be from Philadelphia but live in New York City, and you have a Philadelphia area code. So would you be included in something like the community health survey? That's an important question and limitation. One last word about the wireless-only households. So the National Health Interview Survey releases data that can help survey researchers ensure that the random digit telephone surveys include sufficient numbers of households with only wireless telephones. And if you remember, National Health Interview Survey is done in person, so they can ask about things like, do you have a landline, for example. So if telephone surveys do not include wireless-only households, something called coverage bias can occur, and this results from differences between persons with and without landline telephones for variables of interest. And so this is really an important source of bias that I want you to appreciate. Nearly 2 of every 5 American homes had only wireless telephones in the second half of 2013. And this is really increased, just something that's been increasing and increasing. This is really a phenomenon with younger people, especially. So 2/3 of adults 25 to 29 lived in a wireless-only household. So if you can imagine, if you're doing a survey by telephone and not including wireless phones, you're really missing on a substantial portion of the population, and your estimates are biased and may have very limited use. So as an example of how data might be different, so adults living in wireless-only households had a higher prevalence of having 5 or more alcoholic drinks per day than adults in a landline-only household. And wireless-only adults are more likely to be current smokers. So, if you were to do a survey with only landlines, you'll have falsely reduced estimates biased towards the null because you are not including proportion of the population with a much higher prevalence of whatever you're looking at. In conclusion, monitoring health behaviors and risk factors serves as a critical role for public health surveillance and population health monitoring. Like we talked about, several national, state, and local tools and systems exist, and data from these systems are often publicly available. Let's talk about an application of the surveillance data that the Institute for Implementation Science and Population Health has been at the helm of. And this has been the Ending the AIDS Epidemic in New York Dashboard. And please go to the link here and take a greater look. A little background on the Ending the AIDS Epidemic in New York. The goal was to reduce the annual number of New York of new HIV infections from 3,000 to 750 per year by the end of 2020. And this is a 3-point plan to identify all persons with HIV who remain undiagnosed and link them to healthcare, link and retain those with HIV in healthcare to treat them with anti-HIV therapy to maximize virus suppression so they can remain healthy and prevent further transmission, provide pre-exposure prophylaxis for people who engage in high-risk behaviors to help keep them HIV negative. And as you might be thinking, we can really get at a lot of these different things in this plan using surveillance from surveys. And one of the blueprint recommendations for the Ending the Epidemic was to extend and enhance the use of data to track and report on the initiative's progress. So, and this included the creation of a web-based, public-facing, Ending the Epidemic Dashboard system to broadly disseminate information to stakeholders on the initiative's progress. So this is something that, you know, a member of the general public, an elected official can log into and see how we are doing with ending the HIV/AIDS epidemic in New York. So please go visit the dashboard and take a look, and try to also take a look at some of the sources of data that are being used. And I think you will certainly appreciate that a number of the things like the BRFSS, for example, are being used to in this dashboard, which has a very, very important relevance in this public health initiative.